Nursing care of patients with hematologic disorders.
Usually, every time you have a cut or bruise, your blood clots to stop the bleeding. Clotting is a complex process, and there are four main things that make it possible: platelets or cell fragments, clotting factors, which are special proteins, fibrin, which is a protein mesh made up of a special kind of clotting factor, and finally, other cells, like red and white blood cells. Because clot formation is so important, platelets and clotting factors are always available, floating around in your blood. Now, let's talk about the four steps involved with forming a blood clot. When there is a tear in a blood vessel, the first thing that happens is that the nearby platelets are activated and become sticky. They start sticking to each other and to the sides of the hole in the blood vessel. For small holes, enough platelets usually stick together to form a temporary plug. But a platelet plug isn't strong enough to block the opening for long, so it must be reinforced with other materials. Otherwise, the blood flowing past the hole could wash the plug away. These other materials are called clotting factors. As the clotting factors float by the tear, they become activated or turned on and add themselves to the platelet plug. A special kind of clotting factor can weave itself together with others of the same kind and form a web of fibrous tissue, called fibrin. This web acts like glue and holds the platelets and the other clotting factors together, creating a blood clot. Other cells, like red and white blood cells, can also get caught in this web and help reinforce the clot. It quickly becomes stronger and starts to pull the edges of the hole in the blood vessel together. After the clot has formed, it stays in the hole until the tissue is repaired. When the clot is no longer needed, your body dissolves it.
Bone marrow transplant. For a bone marrow transplant, these patients will need a bone marrow biopsy. This is a minor surgical procedure that requires the patient or guardian to sign a surgical consent form. Autologous bone marrow transplant. The donor is the person themselves. Allogenic bone marrow transplant. The donor is another person whose tissue has the same genetic type as the person needing the transplant. Because tissue types are inherited, similar to hair or eye color, it is more likely that the recipient will find a suitable donor in a brother or sister. Stem cell transplants. They are used to treat people whose stem cells have been damaged by disease or the treatment of a disease. Stem cell transplants can benefit people with a variety of both malignant and non-malignant diseases. It is important as the nurse to be available to answer questions or discuss concerns that the patient may have about stem cell transplant. This will allow the nurse to assess whether a patient needs more information about the procedure. In Hodgkin's lymphoma, the cells in the lymphatic system grow abnormally and may spread beyond the lymphatic system. As Hodgkin's lymphoma progresses, it compromises the body's ability to fight infection. Hodgkin's lymphoma is one of two common types of cancers of the lymphatic system. Chemotherapy is often combined with radiation therapy in people with early-stage classical type Hodgkin's lymphoma. Radiation therapy is typically done after chemotherapy. In advanced Hodgkin's lymphoma, chemotherapy may be used alone or combined with radiation therapy. A stem cell transplant is a treatment to replace diseased bone marrow with healthy stem cells that help grow new bone marrow. A stem cell transplant may be an option if Hodgkin's lymphoma returns despite treatment. Non-Hodgkin's lymphoma is a cancer that originates in your lymphatic system. The lymphatic system is a disease-fighting network that spreads throughout your whole body. In non-Hodgkin's lymphoma, tumors develop from lymphocytes. Treatment is based on the type and stage of lymphoma, and treatment might always be necessary. If the lymphoma appears to be slow-growing, a wait-and-see approach may be an option. If non-Hodgkin's lymphoma is aggressive and causes signs and symptoms, then chemo, radiation, and stem cell may be an option. Rituximab is approved for Food and Drug Administration for the treatment of B-cell lymphoma. There are also radioimmunotherapy drugs are made of monoclonal antibodies that carry radioactive isotopes. This allows the antibody to attach to tumor cells and deliver radiation directly to the cells. The two radioimmunotherapy drugs are imbripumomab and tositumomab, Zevalin or Bexar, and they're both FDA approved to use in people with recurrent lymphoma. In multiple myeloma, a group of abnormal plasma cells, also known as myeloma cells, multiply, raising the number of plasma cells to a higher than normal level. Since these cells normally make proteins, the level of abnormal proteins in the blood also goes up. Health problems caused by multiple myelomas can affect the bones, immune system, kidneys, red blood cell count. Lymph nodes are not enlarged with multiple myeloma. These patients will need a high fluid intake, and urine output helps to prevent complication of kidney stones caused by hypercalcemia and renal failure caused by deposition of Bence-Jones protein in the renal tubules. There is no cure for multiple myeloma. With good treatment results, the patient can usually return to a near normal activity. Neutropenia is an abnormal low count of neutrophils, white blood cells that help the immune system fight off infections, particularly bacteria and fungi. Between 45 and 70% of all white blood cells are neutrophils. The lower the neutrophil count, the more vulnerable to infectious diseases. If the patient has severe neutropenia, fewer than 500, bacteria normally presented in your mouth and digestive tract can cause infections. Patients with neutropenia are at a higher risk for infection when exposed to other patients in the hospital. Pathogens are much higher in the hospital than in the patient's home environment. Although chemotherapy may be stopped with severe neutropenia, these patients are usually taught how to self-administer filgrastim injections, which can usually allow chemotherapy to continue. Thrombocytopenia. This is a disorder of primary hemostasis. With thrombocytopenic purpura, the total number of circulating platelets is greatly reduced. As a result of the decreased platelet count, the patient is at great risk for bleeding. Therapeutic management. If the cause is bone marrow suppression, its watchful waiting and protective measures are instituted. Because of this, anticoagulants may not be given. Also, IM or subcutaneous injection should be avoided because of the risk for bleeding. A soft toothbrush could be used for oral care. Remember, for NCLEX, look for complication versus expectation of a disease process. Bruising is an expectation. Difficulty waking up a patient could be a complication, which means they might indicate a cerebral hemorrhage. If the cause is accelerated platelet destruction by drugs, then stop the drug. If immune-mediated, then may need corticosteroid, splenectomy, or IVIG. Hemolytic-uremic syndrome is a condition that results from abnormal premature destruction of red blood cells. Once this process begins, the damaged red blood cells start to clog the filtering systems in the kidneys, which may eventually cause the life-threatening kidney failure associated with hemolytic-uremic syndrome. Most cases of hemolytic-uremic syndrome occur after E. coli infection, but most often the cause is obscure and unknown. Another disorder of primary hemostasis, primary induced thrombocytopenia. When heparin-induced thrombocytopenia is thought to occur, administration of heparin should be stopped immediately, and alternative anticoagulants which do not cross-react with heparin-dependent antibodies should be initiated. Thrombocytopenia associated with heparin-induced thrombocytopenia has been observed to occur generally 5 to 14 days following the initiation of heparin therapy. However, patients previously exposed to heparin may demonstrate an early reaction which progresses rapidly. It is important to monitor decrease in platelet counts in terms of trend and absolute value. Platelet aggregation in heparin-induced thrombocytopenia causes neutralization of heparin so that the activated partial thromboplastin time, will be shorter. Hemophilia A is the most common type and is caused by lack of clotting factor VIII. Hemophilia B, the second most common type, is caused by lack of clotting factor IX. Hemophilia C, this type is rare in the United States and it has a different inheritance pattern. It's caused by a lack of clotting factor XI, and symptoms are generally mild with this type of hemophilia. Causes include inherited mutation, controlling clotting factors, and the clinical presentation depends on range of severity. Uncontrolled bleeding might be due to inability to form clots. The internal deep bleeding sites include monitoring for excessive bleeding from minor cuts, bruises, or abrasions. Joint and muscle hemorrhages can lead to disabling long-term problems. They have a tendency to bruise easily. Prolonged and potentially fatal hemorrhage after surgery. Nursing management includes rest to minimize bleeding. Ice packs can be used to decrease bleeding. Any range of motion and weight-bearing exercise can begin after bleeding stops. Look for signs of melena, because this could be gastrointestinal bleeding and requires collaborative action such as checking hemoglobin and hematocrit and administration of coagulation factors. The main causes of DIC would be tissue trauma like burns, malignant cancers, liver disease, sepsis. So when we look at this particular one with the platelets, the septic response to bacteria. Remember, disseminated is widely spread. Intravascular means that it's inside the blood vessels, whereas coagulation is now activation of the blood clotting system, as we see here with the clots. The clots stop blood flow and oxygen to the tissues that are downstream, and this causes the tissue cells to die. Disseminated intravascular coagulation. Now, disorders of secondary hemostasis are like vitamin K deficiency, hemophilia, disseminated intravascular coagulation, and aplastic anemia. Now, DIC begins with excessive clotting, persistent activation of the clotting cascade in response to widespread triggers such as depletion of clotting factors and activation of the thrombolytic system. The excessive clotting is usually stimulated by a substance that enters the blood as part of the disease, like infection or certain cancers, or as a complication of childbirth, retention of a dead fetus, or surgery. People who've had severe head injury or have been bitten by a poisonous snake are also at risk. As the clotting factors and platelets are depleted, excessive bleeding occurs. As DIC progresses, bleeding in puncture sites. GI, look for melena. CNS, look for hemorrhagic stroke. Heart, chest pain, shortness of breath. Genitourinary tract, hematuria. Hemodynamic shock from blood loss. Nursing interventions is going to include anticipating DIC in any patient with infection, trauma, any large surgeries, cancer, and obstetric emergency. Assess for early indicators and focus on circulation and oxygenation.